you mentioned, of course, it almost helping for us to understand that there isn't too much specifics beyond its exact benefit for time treatment started. But this new trial presented by NEJM yesterday with 400 patients across a few countries, actually, across the world, essentially randomized to 5-day or 10-day regimens back in March, showed, there was very apparent benefits for clinical improvement as per the 7-point scale that we'll get to in a bit, but also reduced hospitalization rates at the end of 14 days. There was no real significant difference that they noticed, again, between 5-day and 10-day regimens. Jason, can you tell us a little bit about what that specific outcome tells us about the drug?
I honestly don't look at that for that study for efficacy at all. The only real utility to it was, well, there's potential utility to the patients that got it. It was interesting in that, since there was no placebo, everyone was getting treated, but they were getting treated with something we didn't know if it worked. So it was kind of intriguing, going forward within the context of the study. And I'll be quite honest, when I first saw that it was being done, I kind of didn't really know what the point was. But now that it's out there, I'm kind of glad, because since we have this drug in such a limited supply, seeing that there's no apparent benefit to extending the course of therapy to 10 days, as was done in the ACT study, versus a shorter course of 5 days, will at least help us conserve drug. I don't really think there's huge things to take away from it. I think you can get a little over granular with it because it does break it down, as you're mentioning, by the severity of illness of the patients and their risk scores. But I don't see too much utility in that, besides taking away the overall point that there's no apparent difference, whether it's 5 days or 10. And honestly, I think that's not surprising at all.
And, it's actually something that was sort of echoed by editorialists who wrote in on the findings at the same time, emphasizing the need for optimal remdesivir dosage, finding the right patient, the right levels of severity for an efficient amount of time. That's where they see some of this new data coming out as valuable for them to go back and look at, maybe from just a second mindset of, okay, how exactly do we best use this drug in the limited capacity that we have? From that front, and you've sort of answered it, but from that front, have we really improved our understanding of remdesivir optimization?
I think so. I think we've learned that there's a population that seems to benefit and a population that doesn't. Excuse me. And pardon me, that's contagious. That the duration of therapy is unimportant. Well, who knows if 1 day is enough, but that 5 is as good as 10, I think is useful. And whenever we shorten a course of therapy, we decrease the rate of adverse reactions, obviously decrease the exposure to the drug in the patients. While remdesivir seems to be a fairly safe therapy in what's been studied thus far, everything has risks and everything has benefits, or most things have benefits, I guess. So I think that's a plus. And in infectious diseases, we try to shorten courses of therapy overall. It's different on the antibacterial side, which is what I used to be talking about all the time, than it is for antivirals. But I really do think that we've learned a lot. I think there's a lot of big questions that remain in terms of how best to utilize it. There was, going to the ACT study, there's no benefit in those patients who are on the ventilator. Does that mean we don't treat them? If it's a limited supply of drug, I hate to put it this way, and hopefully we don't get to this point, but if you have just enough drug for one patient and you're looking at 2 of them, one fits in the criteria of someone who is likely to get better, and the other one fits the criteria of who is sicker. That's a pretty hard decision for people to make as to where those vials go, even with what the science tells us, because there's the clinical science, and then there's basically the other factors that weigh in. And that will be tough, and I hope it will not be the situation that people are put into. More than anything else, I think that need, and again, relative lack of efficacy in those sicker populations, pushes us towards more therapies being developed specifically for them. And then the other question is, we talk about these things in isolation because we only have this one drug available and other ones in clinical trials, but who's to say that the correct answer is to give people one drug? One thing addressing viral replication and the other one addressing the cytokine storm that patients sometimes reach could be the best approach. And, that's something we'll see in Act Two.
Yeah. I'm interested to see how exactly those findings come to be. And touching back a little bit on what you were just mentioning, obviously, understanding, I guess, the level of care that we can still provide based off of severity, something that became kind of a bigger talking point relative to these new findings from the NEJM paper, were the 7-point ordinal scale that they had set for hospitalized severe COVID patients, ranging everything from death to discharge, really, were the outcomes that they're looking at. And obviously, there's a lot of more intricacy in between those two spectrums than they've laid out at the 7 points. But you and I were just saying before this, obviously, there is some kind of value in having something resembling a universal scale for us to gauge therapies by. And it's something, of course, that I've certainly seen across other specialties when covering is a reliance on a point system for people to understand benefit. All this to ask you, essentially, is the best outcome that we still have right now, even if it's not just for remdesivir, but all the therapies we're assessing, is reduced time in the hospital?
That's an interesting way of asking that. I think that scale is almost a surrogate for that kind of thing. The reason that it was changed to that in the ACT study was to give something that was a little more plausible. As these studies were thrown together, keep in mind, actually, I don't know exactly when that was, but it's not hard to picture that we knew so relatively little about the virus and about the patients that we see. Some of them are out of there in a few days, and some of them are lingering for quite a while. And if you're trying to report results from a study, and you don't want to be stuck waiting to see, the sort of end result of that patient for a long period of time. And even the ACT study is just a preliminary report. Like, there's, things that we could still learn about it. That mortality difference that was insignificant could become significant, or it could completely go away, as we wait for the, I don't know how to say this, but the final outcomes of those patients. But so I don't think these ordinal scales are a bad thing. I think it's a good way of going about it. It's maybe a little confusing that the NIH one and the Gilead one are inverted from each other, but they're both ways of trying to keep objective where a patient sits in terms of their overall status. And I think they're largely successful. Time to discharge is in essence a way, I would say, maybe not objective, or it's objective whether they're in the hospital or not. But if you improve their COVID and now their underlying disease state is holding them there, you know what I mean? But they're off oxygen, is that a failure of a drug? I would say the answer is no. Yeah. And that's part of the reason why these, looking for improvement in this scale is used. And I think it's actually pretty good. I'm content with it.
Yeah. I think it certainly is an interesting representation of where we stand right now. Even for the parts where it might be a little oversimplified case by case, broadly speaking, it does tell a story. It helps interpret a little bit as we're going. So
it makes for some neat looking graphics too in articles. So sometimes they're in the supplement, but they as you said, they help tell the story.